Still 3 minutes. Well, all you have to do is travel for about 3 hours, go to a conference, have 34 PowerPoints, be on a panel, and watch the conference let the person before you go on and on and on and on, and then you get like 12 minutes or 20 minutes, and you still smile and you're gracious, and you're like, why did that happen? How could that happen? So if it happens more than once, you're like, seconds to walk to your chair. It's a good time to just do a little housekeeping. This session features two speakers. Jamila Rashid, her father passed away, so if you believe in sending people loving, supportive energy, it would be a good time to send some to Dr. Rashid. So I'm substituting. And then we have Rosalind Holiday Moore. So we're going to share this time. So I'd like everyone to move in the room to where you think you'll be comfortable. I never like when they tell you, could you please move to the front? I'm like, I'm sitting where I want to sit. Don't tell me to come move to the front. Deal with it, Okay, so we're ready, Joe. Okay. Welcome to our Saturday afternoon program. This is, yes. I'll start over since he's going to edit. Welcome to our Friday afternoon panel. This is session 21F. For those of you who are completing the evaluation forms for CHESS, MCHESS, you will note that if you had an earlier version, it says Dr. Jamila Rashid, as does your program, but because she had a sudden death in her family, I am substituting. So this session is entitled Public and Community Health Workforce Development to Address Health Disparities. So this is my opportunity to explain to you why we even have this conference event. It all goes back to something called the Research Group on Disparities in Health. So specifically, we're talking about the Research Group on Disparities in Health pipeline into careers focused on community health and public health. We'll focus on guiding values and principles for conducting culturally appropriate research. Why bother to create a group on disparities in health, a research group on disparities in health? Well, as you'll see, there were some good reasons. But to be quite honest, I think I want to share something I deleted. And that involves my experience in traveling to Ghana, Africa, and networking. I actually met someone who was about to travel to Ghana at a conference. So I believe that conferences are actually very magical places where you can connect with people and network. And so as a result of my going to a particular session, I was invited to go to Africa. And the experience was such that I ended up getting feedback, which was, it's so strange that you as the first African American woman to move through the ranks and get tenure in the 100-year history of Teachers College, being located in Morningside Heights, meaning that in 1994, I was interviewed by the Teachers College newspaper because, I was the first African American woman in their 100-year history to move through the ranks and get tenure, unlike a few people who were stars like Linda Darling Hammond, who's still a star, who came in with tenure. And right now, I am the only African American full professor. So the feedback I got was, having just gone to Africa, perhaps you can grasp that the natural state of being from the African perspective is that you're a member of a community. So it got me thinking that, yes, I was experiencing what felt like a rather painful isolation at times. And even when Teachers College went through a major reorganization under a new president, and all of these programs came together to form new departments, every other faculty member of color now had a colleague of color except me. So I was still the only one in my program and department. So I began to think, well, I could create community. And one way to do it would be to create the research group on disparities in health and to begin to provide training for pre-doctoral and postdoctoral fellows. And there is a context for this in terms of the rationale. We can turn to a special issue of the journal of the American Journal of Public Health, the work of Stoff et al. And part of what they noted in this special issue was that investigators from socially disadvantaged racial ethnic groups remain significantly underrepresented in the National Institutes of Health research and training grant portfolio. So it might not be as a funded researcher that many individuals are attempting to advance their research agendas and careers. And moreover, Stoff et al. Went so far as to call this underrepresentation a national crisis. Ginther, and perhaps you've heard of this report, Ginther, Schaefer, Schnell, Ginther, and al., in 2011, conducted a research study. They looked at race, ethnicity, and NIH research awards. They hypothesized that scientists of different races and ethnicities with similar research records and affiliations would have similar likelihoods of being awarded research grants. But what they discovered was that there actually was a funding gap. So quite often we talk about health disparities, we talk about inequities, we talk about gaps in health, gaps in education. Well, they found a funding gap based on race and ethnicity. They explored associations between the probability of receiving a National Institutes of Health R01 award and self-reported race or ethnicity. Compared to whites, Asians were 4 percentage points less likely to receive an award. Now, compared to whites, they then found that blacks or African Americans were 13 percentage points less likely to receive an award. So they went on to control for educational background, country of origin, training, prior awards, publication record, employer characteristics, and they found that what remained significant was the manner in which blacks, African Americans were still 10 percentage points less likely than whites to receive an award. And so part of what they note is that throughout the educational pipeline, blacks are less likely to graduate from high school and to go on to attend college or a major in biomedical science, obtain a PhD, things of that sort. But they really expected to find that black scientists who made it to the stage of principal investigator would have similar chances of obtaining NIH funding, with all things being equal. And so they were quite troubled that the typical measures of scientific achievement, like NIH training, previous grants, publications, citations, it did not translate into the same level of application success across race and ethnic groups. And for them to find that the greatest difference was between blacks and whites in terms of the effect of previous training, the probability of receiving a score, that this was really the heart of the funding gap. And so one might go on to ask, what variables might be considered that are operating when you are thinking about how one might increase the likelihood of an application receiving a priority score so that Black investigators would also be funded. And so for those who hear these kind of results, quite often there's a sense of alarm. You mean I get the same training, I have the same loan debt, I have the same publications, and all things being equal, there is a 10 percentage point less likelihood of getting funded compared to a white? Well, one might say that there's an urgent need to respond to this national crisis that Stoffenau described by saying we need to really have change. Or we can use that word that really excites people. It's time for a revolution. But of course, it only means change. It only means transformation, but sometimes makes people a little nervous or excited. So what's needed are more minority students completing doctorates to address the disparities in health plaguing communities of color. That's an urgent need that we can respond to. We may not be able to go to the NIH and say, what are you going to do? What are you going to change? Okay, you've had special population training. You've done various things to increase the likelihood that more minorities are going to get funded. But guess what? After a decade and more of doing this, it's not working. But what we can do in places such as academia is we can focus on ensuring that more minority students complete doctorates. And we can also talk in terms of a broader diversity that involves also women advancing, so that they are able to complete their doctorates. And why? Why bother? Because we're thinking that those who may be from communities where there are health disparities might bring a certain sensitivity to the task of focusing on health issues, community health, public health issues, to help us to move toward the reduction and elimination of health disparities. So yes, let's train individuals from those communities who may have a sense of wanting to go home and to address the health issues. So there are barriers in academia. So it turns out that even though we may be of goodwill and intend to graduate more diverse students, women, students of color, guess what? There end up being barriers in academia. So Cargill is the one who asked the question in this special issue, is it possible that despite our best intention, we here in academia are actually creating or maintaining barriers to the development of minority investigators? Oh, how could that be? Well, there are ways to overcome such barriers. One barrier involves the shortage of mentors. Okay, so part of what I just described to you is that in 1994, I was acknowledged as the first African-American woman to move through the ranks and gain tenure in the 100-year history of the institution. I think you get the point that, yes, there can be barriers in terms of shortage of available mentors who are capable of effectively training the next generation of researchers who are women and members of historically marginalized and oppressed groups. So how do we overcome that barrier in academia? As I said, I had traveled to Ghana. It had occurred to me that it is true. I am quite isolated in an institution and in a program and department where I am the only one. And even among all the faculty of color, I am the only one without a colleague when I go to my program and departmental meetings. So I viewed my emerging and expanding consciousness and appreciation of things African from the perspective of, this is actually an African technology to think in terms of doing things communally and collectively. It's actually a technology. It's a kind of expertise. What is it that African culture or Asian culture or Hispanic culture has discovered where there is something to valuing the group There's something to valuing a communal or collective approach as to an individualistic, competitive approach. So embracing this African technology, and specifically African ways of communicating ideas and educating, I decided to collaborate with other professors as well as various group members who were part of the research group on disparities in health. And we would use a communal group setting, specifically a Wednesday seminar, as our opportunity to meet every week. Now, for those of you who have received advisement doing either your master's degree or your MPH or a doctorate, you know that a very classic model involves going to the office of your advisor and sitting down one-on-one and talking about your research project. So what we did instead was eliminated those one-on-one individual meetings and instilled the value of coming together as a communal group, as a collective, viewing everyone as equal, everyone being able to make contributions to the development and evolution of research projects, using this African technology that there's something about coming together as a communal group, as a collective. And so we could also overcome the barrier of a shortage of mentors, because we would recognize that there's expertise within the group. You are a registered nurse. You are a master's of public health who's focused on environmental issues. You happen to be a social worker pursuing your doctorate who has a certain background or training. You're a psychologist. Everyone brought a certain amount of expertise as adults in graduate school. And we also used peer mentoring that quite often I would group people together. And I basically asked them to be a support system for each other and to be in touch with each other. And so that even outside of our group meetings, these buddy pairs would be able to talk on the phone, criticize Professor Wallace, complain about Professor Wallace. Because the best way to experience unity is to find someone who you can get angry with. So I always tell students that always make me the bad person, okay? If you need to get something at the registrar's office or you need to get something from the financial aid office, complain about me. I am the one who's making you go and do this and ask these questions. And so the idea is that we follow a concept of Gaston and Porter in terms of positive and optimistic social support. That it's not about criticizing and complaining, although I would encourage them to do that so they could bond. Ultimately, they do have this sense that there's something positive that we're getting from Professor Wallace. But that positive and optimistic social support was still the concept of how we could apply this African technology, that social support, and coming from the perspective of a collective is so very important. Secondly, there is the barrier of a lack of cultural competency training and lack of sufficient attention paid to health disparities in graduate training programs in the United States. Now, you would think in the new millennium that this is not true. I actually had a conversation with a graduate student just the other day, which of course was one of these super confidential conversations where she had raised issues of culture in the course and asked the professor a certain question, and the response that she got was just shocking to her. And I said, well, it's all about adaptively coping, because what you can get from that course is X, Y, and Z. So get X, Y, and Z. If you want more, then you need to do independent research that's going to allow you to get the cultural component that you feel is missing from that course, because we face the reality that you cannot make a tenured full professor do anything. You certainly can't make them a trained man. You cannot make them attend mandatory cultural competence training. It's even difficult to get them to attend mandatory sexual harassment training that you need for your insurance at the university. And so what we end up emphasizing is, yes, we need to create safe communal spaces where we can talk, not about the other professors who aren't doing this, but we can talk about how is it that we pursue cultural competency? How is it that we find places where we can kind of feed this empty space where we're yearning for something that's culturally relevant? Why? Because we may ourselves, as either women or members of various racial, ethnic, immigrant groups, we may have this sense that there's something that's unique to our experience, something that we also may share in common with others, where we feel that we do want to pay attention to issues of culture. So we overcome this barrier through cultural competency training. So fortunately, I have engaged in writing for over a decade, and it was such that it was recognized as unusual and outstanding in terms of the psychology of ethnic minority issues. So I became a fellow in the American Psychological Association. So I'd like to think that my needing to focus on culture, my needing to create approaches to diversity training and multiculturalism, my need to pursue publications in that area bore fruit, where I think that I can bring in that communal group setting and also offer articles for my students to read that are going to provide them with a cultural lens, so that when they engage in research, it is okay. As a matter of fact, it's really extremely critical that they are paying attention to issues of culture. And so that communal group setting becomes a safe place where we can now talk about cultural issues. Yes, I want to focus on food for my dissertation, but I have been doing a search, Professor Wallace, and some of the questions on those surveys just have nothing to do with what goes on in my grandmother's kitchen, which is where I learned how to eat. Whether it's my Puerto Rican or Dominican or African American or Jamaican grandmother, there's something cultural around food that I feel as though I want to put into my survey. So guess what we have to do? We end up having focus groups in that same Wednesday research seminar. Okay, how convenient to be able to have a focus group at the drop of a hat. Okay, we're gonna have a focus group. This is the question. Okay, and so we end up coming up with critical themes, and then we take those themes and they become survey items. I was once working with a nurse who had a very long career at Harlem Hospital. And as a matter of fact, this is the type of person who just went down to ground zero after 9/11. Really a remarkable human being. And so we wanted to look at the experience of nurses in various hospital settings and how they cope and respond when they perceive discrimination occurring in the hospital setting. For those of you who were here this morning and listened ever so carefully to Dr. Williams, he informed us that the perception of racism and discrimination is alive and well. So we wanted to identify all of the various situations in a hospital setting where a nurse might be able to witness discrimination occurring. And after I interviewed her this is actually before the research, I interviewed her for about an hour, and I said, you know what? We don't need to do a focus group because you know so much about every conceivable situation that occurs in the hospital that, we already have like 40 items on this survey. So the idea is that our students are bringing expertise. We respect them as equals. We can have an interview, we can have a focus group, and we end up designing survey after survey after survey that becomes the culturally appropriate tool that is something that the student could not find in the literature review. And that becomes important when we talk about making sure that our students are engaging in research that reflects cultural competency training. So the research group on disparities of health has become a pipeline for public community health research training. It represents a timely response to the harsh and painful reality that African American researchers have for a considerably long period of time needed to find viable mechanisms for conducting research, and these mechanisms are different from those who may be white researchers taking the NIH route, given the all too common experience of exclusion from the NIH funding stream, as was documented in the article we discussed earlier. I also had an interesting experience here at Teachers College where there were some rather strange emails going around. And this was early on when we had email. This was in the fall of 1998. And we actually had a faculty meeting where there were a lot of multicultural jokes that had been told, but it turned out that they all just seemed very racist. And so the junior faculty were feeling very distressed. Why do I want to be here? This was the conversation they were having. So I was like, well, you know what? Right now, I'm the only tenured African-American professor at Teachers College, so I think I can speak up and I can respond to this. As a part of my response, one day there were 12,000 emails sent that February in response to an email that I had sent, and they threatened to shut down the entire email system. And I merely asked the question, have you consulted your lawyers about this? And personally, I think that there are still some faculty members who recall those days and may not have embraced the spirit of multiculturalism that actually led to the creation of Office of Diversity and Community here 9 months after a series of meetings and a report I submitted. And I discovered that when I now submitted or signed off on my doctoral students' applications to the Institutional Review Board, it seemed like they were being very, very picky. So I decided, you know what? We need to start doing research that is exempt from IRB review. So we actually started actively pioneering online research and have made tremendous advances in how to conduct online focus groups, how to conduct online surveys, and we have really made significant strides in really pushing the barriers away and engaging in research that doesn't require NIH funding, but actually is very significant, often in accessing groups that are underrepresented in the literature. I mean, how many research samples of, for example, 240 African-American women where the mean income is $70,000? Yet there are a lot of African-American women who are just astounded to be able to see themselves reflected in research that is very relevant to they're still having a risk for HIV infection, for example, or to diabetes or obesity. And so we've really been able to make interesting contributions. So we see the research group on disparities in health as really providing a national and international resource while providing needed training. And in particular, there are 3 things that we focus upon or seek to teach in the setting of the research group, the research seminar. The vision is that we are actually training leaders, leaders for a global movement for equity in health for all. I'm glad one person laughed. This is one of my doctoral students. So we hear many various organizations, the Commission on the Social Determinants of Health talked about a global movement for equity in health for all in my 2008 edited volume that's referenced here. There's discussion about a 21st century global civil rights movement for equity in health for all. And so we're training global leaders to provide leadership in that movement through the research group. We are training in culturally appropriate research so that our students can approach national epidemics, global pandemics that disproportionately impact members of historically marginalized and oppressed groups. And we're also training to develop and implement culturally appropriate models so they have the knowledge and skills for developing and implementing culturally appropriate health education, prevention, intervention. Many of our students are also developing and pioneering work as professors in departments of health across the nation, department chairs in various programs in health, so that their models include training undergraduates as well as graduates. So what is the vision? The vision of the research group on disparities in health that guides the work that we engage in involves increasing the number of graduates with doctorates in health education and research investigators who are women and from historically marginalized and oppressed groups. The intent is that they are prepared for success in receiving grants, funding, while pioneering a new generation of culturally appropriate health disparities research. So many of our students work in the quote-unquote research shops where there may be a grant-funded study that's going on somewhere in New York City, someone who has received NIH funding. And we certainly encourage them to do all they can to become a permanent member of that shop. So they might eventually move up to being a co-investigator and eventually put forward as the principal investigator. But at the same time, we are allowing them to put on the lens of culture. So even when they go to that research shop, they might have a slightly different perspective on what they're witnessing when they are working with some of the funded principal investigators, or they may appreciate that they're working with someone like Nabila El-Basil at the School of Social Work, who is pioneering culturally appropriate methods of research, and they're delighted to be a part of that particular shop. Our mission involves focusing on the successful completion of the doctoral dissertation through research that is culturally appropriate and results in that good old thing called not just debt, but graduation with a degree. Okay? So that I feel very strongly that we have a moral, ethical imperative, not only to invite diverse students into our program so they can take our graduate level courses and go into $100,000 in debt and potentially be all but dissertation. No, the goal is that they complete, and they complete in a timely fashion. My personal philosophy, now that we have really advanced online research, to sum it up, if a woman can have a baby in 9 months, a dissertation can be completed in 9 months, if you are willing to fast track and work very, very hard. So what is the African technology? We value African traditions, such as working in a communal collective setting. That means that when you are in that group on a Wednesday afternoon and you are given some feedback that, you know, and I love the group setting. It's kind of like group therapy. I'm a clinical psychologist. So I used to love working in substance abuse treatment where it's clear that a woman in the group is getting very angry at another woman, and she is literally seeing this other woman as her mother with whom she has issues. I might be that woman, and the client is angry at me. And so it's wonderful to say, does anyone have any feedback for Mary? Okay, and because they've been in the group for a while, they've been trained how to be some of the very best group therapists. As a matter of fact, I used to take some of the master's degree students with me on my Friday consultation work. And the clients who'd been in the group for 6 or 9 months were always better co-therapists than the master's students in clinical and counseling psychology. So the concept is, who wants to be the messenger? Sometimes the messenger gets killed. So we do the same thing in the research seminar. Not too long ago, I had received an assignment from a student, and I looked at it quickly, and I was like, oh my God, this is horrible. So what did I do? The student showed up. I said, wait, we're going to have a focus group. Okay, let's all review this. Okay, let's have a focus group. What do you think? Let's go around, everyone. So clearly, they squashed the project rather effectively, because it was clear that it was deficient. It wasn't up to par. But I didn't have to be the messenger, you see. So this is a part of the advantage of having a communal group setting where we're treating everyone as equal. We have expertise. Anyone with common sense could see that it sucked. It was horrible. But I didn't have to jeopardize my relationship with the student because of this African tradition of let's come together communally and share, engage in oral communication with cooperation, with collaboration, with partnerships, and adopting African ways of educating and communicating ideas and traditions, such as communal groups, songs. A song, okay, you heard of call and response songs in the African tradition. If you go to a Black church, you may also hear the call and response song. Well, guess what affirmations are in many respects? So there's absolutely no one who's interacted with me for more than 3 months who hasn't been taught to repeat, I am calm, centered, and balanced. I am calm, centered, and balanced. If I say it one more time, I might fall asleep. I am calm, centered, and balanced. So that quite often, because it's an anxiety-provoking experience to engage in research as a doctoral student, I may have to literally stop a student and say, did you do your affirmation? It's like, okay, let's not talk about that. Why don't you, hey, let's all do it together now. because it's a tense moment. You know, I don't want to get attacked. Let's all repeat it together. I am calm. Let's do it 9 times. Close your eyes and visualize yourself on a beach. I am calm, centered, and balanced. And so the energy shifts in the room. Now we can slaughter the idea that is horrible. if that's what needs to happen, or we can come together and have a clear, calm space where we can collectively generate something that is vibrant and exciting. And now I use the metaphor of popcorn. You know, we can start popping popcorn. Ideas just start generating because it's a nice, clear, calm space, and we are just coming up with some great ideas. And I do the kind of advisement where I ask a student, so what do you want to be when you grow up? Okay. In other words, what kind of presentation do you see yourself wanting to do at the American Public Health Association? And so how does this dissertation idea link to your career goal? I had a student a few weeks ago, right before Obama announced the White House initiative on college sexual assault. And so I did this kind of interview with the student. She wanted to focus on pornography, and I'm like, okay, let's see, are you gonna really go, are you gonna be a great expert as a woman, feminist, going to talk to men about pornography? I just didn't see it. I did see her, however, being an excellent consultant to various deans of student affairs offices. Let's do a wonderful college sexual assault study. And so what happened after Obama's announcement, this is the hot topic. Oh, Professor Wallace, thank you so much. But the idea is, how do we make it relevant to your life as well, so it's practical? How do we make it exciting? And so we do use effective contemporary approaches of value that produce positive outcomes. For me, anyone who knows me, they know I'm obsessed with self-efficacy. I don't want to talk about self-esteem. That's not a variable for research. I was once in Florida in a hot tub, and some graduate students were there, and she says, oh, I think I want to focus on self-esteem. I'm like, how about the level of confidence to actually engage in a behavior? Something that, and let's integrate that with theories of relapse prevention and motivational interviewing and stages of change. Now that's exciting. Diffusion of the innovation, of doing e-health, of doing online interventions. So we do want to integrate the use of evidence-based approaches. And most importantly, we want to ensure equal access to opportunities for all. I have a colleague, which means that I am not the professor who's going to tell you, I'm just not interested in that topic. Maybe you should go talk to another professor. Okay, because we're going to make the opportunity to be a part of the research group something that is open to all. The joke is that on my door there's an invisible sign. Give me your tired, your huddled masses yearning to be free. They want to graduate. They've suffered enough. Go see Professor Wallace, because she's going to provide equal access to the opportunity of being a part of the research group to everyone. As long as you're willing to cry with us in group, attend group, have a spontaneous focus group, get feedback, and work very, very hard and master APA so that it is impeccable, your knowledge and use of the APA system of referencing and things of that sort. And then we also, because, give me your huddled masses yearning to be free. Well, it's part of our philosophy, comes from the work of Paulo Freire, Pedagogy of the Oppressed, that education should be about liberating the oppressed. Okay, so if you're working with women and members of various minority groups, and if they live in the same world that Dr. Williams described this morning, they indeed may be oppressed. If my dollar is worth 5 cents compared to someone whose dollar is worth 100 pennies, then I'd say that there could be some need for liberation from oppression. And let's get you a doctorate so you can begin to have access to more opportunities. Isn't that a great idea? Yes. So let's get you out of here as soon as possible. And so not a rigid conformity. Oh, we meet one-on-one. This is how we do dissertation advisement. No, if you have to cry, you're going to cry in front of all 7 of us. We may even cry with you. And so we are not tied to the rigid conformity of a competitive, individualistic approach to academia and experiences in academia. So we support the development and healing of the identity of the oppressed as part of the process of their liberation from oppression. So what's the good old self-regulation for that? I am calm, centered, and balanced. I am calm, centered, and balanced. And so we use the communal group setting. We use the problem-posing concept of education. We rely on dialogue, where there's true reflection and action upon reality, again, from pedagogy of the oppressed. The problem that we pose in our communal groups is how do we best respond to the gaps in health or disparities between racial, ethnic, and other demographic groups? And the intent is that we graduate historically unprecedented high numbers of new doctorates who are women and from historically oppressed and marginalized groups. And to quote a colleague of mine, it's the most revolutionary thing we can do because it represents a real commitment and it's a little different. So I already shared that about my background with you, so I'll move on. It's a way to respond to the shortage of doctorates and researchers who have the sensitivity to really focus on health disparities impacting people of color or women, like college sexual assault, that we have small communal group meetings, we use buddies. Then we have the large communal group meeting, and we also have week-long boot camps where we may come together and from 9 o'clock a.m. to 9 o'clock p.m. for 10 days, come together and get it done, whether it's over winter break or spring break. And of course, I have a couple of doctoral students in here who are looking at me like, Professor Wallace, you are lying. It's not always 9 a.m. to 9 p.m. Sometimes it's like up 2 days in a row. Okay, I cleaned it up just a little bit. But I'm moving away from that. Now we can do virtual boot camps. We all commit that we're going to work all day at home, and email is there, and we can quickly have a conversation. We can, just dial each other up on the cell phone. But, it's about the discipline to actually sit and write for 16 hours a day. That's really what it takes to get a dissertation done in 9 months, that you've got to do it. And it's just a matter of that. And of course, what does that mean? That means that you call in sick from work because you build up to that. You may need to learn how to work Friday, Saturday, Sunday, Monday. So there's the best thing for the 9-month dissertation is something called the flu that you don't have. So you have to really be careful. Because when you call in and say, I'm sick, you cannot get sick. So you've got to I'm calm, centered, and balanced, I'm not sick, oh, I feel great. But about 5% of the time, people actually get sick. We haven't had too many communal group meals, but we used to do that a lot. And most importantly, we have this 2-day annual conference, which is really the ultimate communal experience of transformation, of healing, of getting the exposure to culture that we all need. And it's also about shifting away from the old oppressive paradigm of isolation, of individualism, of competition, profits before people, those kind of values. We're shifting away from identity where we might seek to emulate a white male researcher. Of course, I must admit, there were times that I felt like, am I living my whole life just to become a white male? Is that what I'm supposed to do? It's like, I'm not sure if that's supposed to be my destiny, that I'm supposed to be doing everything I can to be just like a white male. So we tend to really, and there may not be a priority on engagement in culturally appropriate research. It may be more about a record of research and establish the profession that's consistent with the old paradigm and dynamics of oppression, which I describe as A over B, someone superior in the top position, someone inferior in the bottom position. That's the psychology of oppression. And instead, we shift toward a new liberating paradigm that guides education, where we're working in a community and we are experiencing connection to the communities of immigrants, international students, and they also are seeking to do research that connects them with their home. I'm thinking of a student of mine from Sierra Leone who planned to look at, immigrants and heart disease. He went home and found out that in post-war Sierra Leone, the rates at which people were dying from AIDS were just phenomenal. So he wanted to do something in terms of going back home, and that became the beginning of a major program involving the creation of a peer education program for HIV/AIDS prevention, training peer educators, that we ended up doing in Haiti during 3 hurricanes. That was also done in Togo, that was done in Philadelphia, that was done in New Delhi, India, and then we did the preliminary qualitative research to adapt it for Kenya and also Jamaica, but did not have subsequent funding to do that. But the idea is that in this new liberating paradigm that guides education, we value, once again, cooperation, collectivism, interdependence, where we put people before profits. And we are shifting our identity so that we're basing our identity in multicultural awareness. This involves engagement in culturally appropriate research and the design of culturally appropriate interventions. And we accumulate a record of research and establishing a profession based on the new paradigm and dynamics of liberation, summarized as A equals B. That is a non-hierarchical equality. And that's what this symbol is that you see in the program. We now are housed within the Center for Health Equity and Urban Science Education, but that yellow arrow is about shifting. We are crossing out A over B with the red cross-out sign, and we're shifting to equality. So we're going from health inequity to equity in health. We're moving away from the old paradigm of hierarchical domination, oppression, and old ways of thinking and behaving to a new non-hierarchical equality, and we are all experts in that research seminar, and everyone's opinion is valid, and that focus groups allows the whole group to say what I think, then we are really moving toward really respecting everyone there as an equal because they are professionals. And we're really fostering a 21st century global and civil rights movement for equity and health for all. And we have the journal. So at the reception today, the latest issue of the Journal of Equity of Health, which is an initiative of the research group, will be available. The 2008 volume. I had a student the other day who actually told me, after having read about the first 4, we're only supposed to read 3 chapters, but this particular graduate student went and then read about 5 chapters, and she said, when I was working on my MPH, I used to cry all the time because I never got to read anything like this. And she was just so happy. I said, well, okay, let's let them know I paid you to say that. And meanwhile, you've just earned your A+. But that's how she felt, that it was truly refreshing to have a perspective that included culture. And so we have this annual Health Disparities Conference because it was created as a collective, in a collective group setting, with professors, Professor Robert Fulliloff, Professor Edmund Gordon, who you know is the Professor Emeritus of Psychology and Education here at Teachers College at Yale. So this is not exactly a lightweight, this is a heavy hitter, as well as some others and our graduate students. And we designed this model collectively, that it should have a community health fair, that it should be open to members of the community, that we should have some communal activities, that we should focus on Friday on something that's really going to feed academics, and also something on Saturday that's really going to make the community feel comfortable, whether that's where we focus on community-based participatory research, for example. And we should also have a cultural opening. So there are guiding principles that I mentioned, so I won't go into detail about that one again. In the very first conference, we declared a decade of health disparity reduction in 2006, moving toward evidence-based approaches. And again, you see my favorite theory, cities of change, motivation interviewing, relapse prevention, a theory like self-efficacy now, diffusion of innovations. And through my own lectures and dialogue, I really share a multicultural approach. Now, what are the 9 principles for conducting culturally appropriate research? Now, this is the model that I articulate to my students in the research seminar. Sometimes they have to ask a question and they kind of draw it out of me because I haven't really published exactly what's in this PowerPoint. So it ends up kind of becoming like a bully pulpit. Okay, for 5 minutes, I'm gonna talk about how You are not going to engage in research that involves a blame the victim approach. Okay? In addition, the problem with the blame the victim approach is that you identify the factors responsible for the condition as within the individual. What about a social context? What about racism in a social context? In addition, why isn't this advancing? Maybe it is. We avoid a deficit-oriented approach. Again, we're focused on deficits within the individual as opposed to what's going on in a social context. We're going to create, as we do on a regular basis, new culturally appropriate measures that are adequate to the task of tapping into the reality of the historically marginalized and oppressed. We investigate social determinants. We focus on stress in the social environment. We focus on strengths, adaptive patterns of coping. How do people cope? Isn't it wonderful if there is stress? Well, if we ask 200 people, well, how do you cope with it? We may actually find what's critical to create an intervention because the individual in that situation, similar to other members of that population, able to say, this is how I cope. And we're like, wow, let's share that with the other 199 people who didn't figure that out because that sounds like a really wonderful, brilliant way to adaptively cope. We conduct research that involves giving something back to the community. We like to create entire websites where we host our research studies and people can go back. Okay, you're giving me 35 minutes answering a survey. I'm giving you an entire website with 16 YouTube videos that are showing you how to cope in high-risk situations. And that's what you're getting back. Recently, we've been doing brief interventions online where we basically assess certain skills, certain variables. They go and watch a series of videos, and they come back, and we ask them questions, and we see increases in self-efficacy, movement across stages of change, things of that sort. So what is the evidence that this approach works? Well, of course, I got tenure in 4 years, so I came in 1990. I had tenure by 1994. Of course, becoming full professor was another story. That took another 13 years. But as you can see, before the research group, over that 9-year period, I graduated 23 students. You can see 2 were African American, 9 were white, 9 immigrants, only 2 Hispanic, 1 international. But what about after the research group on disparities in health? Wow, look at this. We see 30 African Americans, 7 Hispanics, 34 immigrants, okay? And what about the total, 84 altogether, after the first decade of the research group, and 58 were of African descent. So that includes Jamaican, Trinidadian, other kinds of immigrants. And we also, before the research group, we had 1 openly gay. After the research group, we've had 4. So what I'd like to share with you are some of those graduates, because a picture is worth 1,000 words. And so this is the class of 206 with 11. Now, what's interesting, talk about racism. Why is it that the only white woman has become a department chair twice, while some of the others in this group have had some difficulty even getting jobs? David Brown is presenting. He's at Mississippi, Jackson, Mississippi. Okay. The class of 2008, this was our Haitian Nation. We created Haitian Station on a website because we had so many Haitians. We made videos in Creole. Class of 2009, I thought, okay, no more big groups. This is great. Just 3 this year. 1 Haitian, 1 East Asian Indian. But then the next year, bumper crop. 16, 2 people with disabilities. And then after my sabbatical, just 1 oral defense, but she wanted to march the next year. And so that was the grade 8 of 2012. That was the year we had 5 African-American females, bumper crop, and 1 Hispanic. And then the class of 2013, they made signs because I told them I wouldn't be there because I was at the Cancer Treatment Centers of America with my brother who was dying of cancer. But I ended up showing up, and they were so happy. So this is the photograph of our diverse group. And out of this group, we have 5 presenting at the conference this weekend. So The bottom line is I express my deepest gratitude for this opportunity to share about one pipeline that's helping to create diversity in our community health and public health workforce. Thank you very much. So, we're going to move directly into the next talk, and we will need your help.
This is yours?
Okay, so now I'm doing just this?
Yep, right there.
Oh, this one, okay. So of course, that was a tough act to follow, right? But I'm calm, I'm centered, and I'm balanced. I'm also excited to be here. And I think that's the most important message to start with. It's been a long time since I've been at Teachers College. I had forgotten how long it had been until I turned the corner this morning. Many things have changed, and some things have not. But the good thing is, the changes that I see here are also the changes that I see in my office. I work at the Substance Abuse and Mental Health Services Administration in the Washington, D.C. area, specifically in the Office of Behavioral Health Equity. And I share that with you, not because it's such a big deal, but because I want you to know that my office and 5 others in the Department of Health and Human Services are the tangible outcomes of the Affordable Care Act. If it were not for that act, I'd be working somewhere, but I wouldn't be working there. And sometimes we lose sight of how policy translates to reality. So as I go through today, I'm going to share a little bit more about the realities that we share. Some we want to be different, and some we're glad that they're the same. So as I move forward, I'm going to be talking about student health, specifically student behavioral health. For us, that combines mental health and substance use issues, and how that impacts academic success and careers of choice. I have the privilege, the great fortune of following a series of speakers who have set the stage, so there's no question in my mind that we are of the same thinking and in agreement that something needs to be different. Following Dr. Wallace, I see many things are different here, and I'm really glad about that. Because while you may be one, I was one of 3, so that's not really that great either. To know that those numbers are rising means that more than one is taking a stand. And in taking that stand, I'm asking all of you to do that today. So here's where I start. Charging everyone to remove the masks that we wear every day. The masks that allow us to walk through whatever path our lives have put us on, so that we don't have to see what is most visible. And as we remove those masks, then we begin to understand that the numbers we have been focusing upon today, the conditions of life that determine how healthy we are, impact every one of us. But most importantly, when we're thinking about that pipeline, everyone that walks through the door of any institution has been touched by the conditions of life that impact how well we are, how successful we are, how successful we become. That's the stage for my discussion. Are you willing to remove the mask that you wear? Actually, we have no choice, because everyone before me has taken it off, little by little by little. So I'm going to start with some data as well. Of course, I have a fuzzy slide because I didn't make it myself. I own that. But it doesn't change the point. The slide talks about the changing faces of America. Everyone's heard that. It becomes very trendy. There are tweets all over the place about the changing face of America based on the US Census data. Okay, well, here's where the math starts to come off. The faces of America are not changing. The faces of America have changed. So we make it as if it's about to happen. It has already happened. Look at the bars. So if you just look at the colors, that's all you have to focus on. The red bars, maroon for some, reflect the white population. They're going down. They didn't just start going down yesterday. So this isn't something that's about to happen. It is progressively moving down. And the diversity of our nation is increasing. That's all that's about. Then we look at, as the population is becoming more diverse, if we ask people, what do you think about your health? How healthy are you? Do you feel like you're doing okay? Well, the majority of the white population said, yeah, I'm doing pretty good. But look at who's falling under that. Everyone who's of a diverse background. So if we know things are changing, we know people are saying, if you just look at how I'm living day to day, I really don't see myself doing as well as the rest of the American population, the majority base of this nation, then you begin to wonder, who's really in that pipeline? Those that say I'm strong and ready for the challenge, or those who are saying, well, not today. The other part that we want to look at is, as we examine the pipeline, it's easy to run the numbers to say, well, we don't have a diverse workforce, but it's better than it was. But look at it, comparing it to the population. So here I've pulled out snapshots just around psychologists. Who's working with the people? So if we look at white, non-Hispanic, the red bar talks about the psychologists, and we're going to assume that they've gone through all those little steps and they've got the licensure that they need. That may or may not be the case sometimes, but we're going to make that assumption here. Look how many psychologists are available for the population when you do matching, just by race and ethnicity. The next group, Black African American, non-Hispanic. Okay, so now we're about half of the population. So when you hear those conversations about, we need concordance, we need people working with people who understand the culture, who can relate to the experiences, not because they passed the exam, but because they share the life experience. These numbers tell a different story. It's not about the percentage who graduate always. It's about the percentage who's actually made the commitment to return to the populations that need help the most. So now we have the changing faces of America, the diverse population saying, I'm not doing as great as I thought I could or as I see other people. And then we also see, well, when we look at who's graduating and who's working with the people, there's also a disconnect there that's significant. And it's not just for one group, it's for all groups, some significantly positive, some significantly negative. So then we go to, okay, well, what's going on with the folks? Who are these people that are in our pipeline? So this slide, not that I think anyone's really focused on psychopharmacology, although that was one of my favorites. These are medications that look at anxiety. So across all groups, regardless of age, this graph shows you treatment episodes and admission data. So from 2000 to 2010, all you have to do is look at the upswing. People are more anxious, and they're taking more medication, sometimes with prescriptions, sometimes they're borrowing prescriptions. So we get to that substance misuse. So that's another growing issue. But I bring this up for one primary reason, and I want you to just focus on the red arrow here, because we're talking about the readiness for the pipeline. So the arrow is pointing to the group ages 18 to 24. So most of those folks would be eligible for college. Look at the differences in the use of anxiety medications that trigger admissions. So the dark brown bar is showing the percentage of admissions that are based upon heightened anxiety and the use of medication. The lighter bar shows all other admissions, so other substances that you might be using. Neither one is good, but it's letting us know that people are coming forward ready for study in a place that is not balanced, centered, and Dr. Wallace, there you go. That's a problem. So we're beginning to recognize that as the population's changing, a lot of the stressors that we've talked about are having a very important effect on at a critical age. So here, this is the readiness. Here it's high school to college. And we start to look at, okay, so you've got these heightened anxieties. We know there are a lot of social determinants and all these words that we throw around. What's actually happening? So we look at causes of death for Black youth. Top cause, homicide. Next cause, accidents. If you go all the way down to the bottom of the slide, suicide, violence, anxiety, violence. They go together, but not in a good way. Now this one, really important. The use of illicit drugs. We see it in the news all the time. I think we're almost saturated with it. But here it's showing you that the percentage of U.S. youths using illicit drugs did not change significantly from 2008 to 2012. So people say, that's great, right? Things are at least not worse. Except for whom? Look at this, the line, the solid line that goes across. It's the little skinny blue one. And it's showing you the trajectory of Black youth. They are the only ones where the increase in illicit drug use was noted. So while across the board we can look at the data and say, oh, it's really not getting significantly worse, it is for one group. Again, we see a pattern, a heightened anxiety, impacted by violence, and now here we have with substances. So who gets help? Here we're looking at age 12 to 17 with a major depressive episode. 63% of those saying, I need help, didn't get help. So again, think about the pipeline. So if you're at that point where you're in the advanced placement programs, you're thinking about those special opportunities, mentors attracting, no, that's not there for you either. So we started to think about, what does this mean in terms of our workforce development? All things are not equal. So how do we adjust for that? How do we begin to understand the impact of these conditions on the possibilities of students coming in, graduating on time, and having careers of choice? Because we see that the same psychological issues that affect the entire population are also affecting those that we are envisioning as our emerging professional community. So we took another perspective. So where are these young people? Where can we go to think about the largest group of diverse students who potentially will be coming into the behavioral health career path? We looked across minority-serving institutions. And when we looked at that, we see a difference between the enrollments. So the blue bar is showing you the percent of institutions that are minority serving institutions compared to majority white institutions. So you see the blue bars are much smaller. But the red bar is showing you those who graduate or those who are enrolled in the programs looking forward to professional careers. So here we see that increased potential. So they may be smaller in numbers, but the numbers of students coming out and then going into professional paths is greater. So within SAMHSA, we had a relationship with a group of historically black colleges and universities, and we thought about it for a while, and things were going well. We had a lot of collaborative dialogues, but I don't know about where you are. Collaborative dialogues tend not to generate great data. They generate great conversation. So when someone turns around and says, so how are you doing? What changes have you made? Should we invest again? And it's like, well, who's got the data? So everyone's looking, no data. So we said, all right, we still want to keep the collaborative framework, but we have to change. We have to do something differently. So we reconfigured our model. This was back in 2005. We decided at that point, and I'm struck by the similarities here, that we would create a funding opportunity for one institution, the opportunity open to all. But in looking at creating a network or a framework that had more of a possibility of bringing people together as opposed to smaller buckets of dollars that everyone's going to scramble for. So here's one, but if you get the money, you make a commitment that you must bring everybody along. And the grant focused on two primary things: that we wanted to increase the diversity in the behavioral health workforce, and that we wanted to address disparities in behavioral health outcomes. And those disparities started with students. We know they're coming into institutions with disparities. The course of their stay, those disparities didn't go away. And at the same time, we say, okay, so now we need to make sure that we do something differently. So this model is inclusive of all 105 HBCUs. It's aligned with federal and university priorities, which means the federal government, of course, has what it wants. That's just the nature of the game. But our goal is simple. But it also leaves room for each of those 105 universities to prioritize what's important for their institution, because we recognize that each one of them is different and that the students that come to those campuses are different, but that we're all coming together for a common goal. We continuously promote collaboration within and across HBCUs, and that because the dollars are limited, we are looking to see how can we honor and leverage existing resources both within individual campuses, within our programs, and across campuses, really facilitating that collaboration so that we're strengthening a network. We have three primary goals. One, promoting student behavioral health. Critical, critical. It's a retention factor that we cannot underestimate. We look at academic success and careers of choice as our metric. Expanding behavioral health service capacity goes two ways. One, on the campus, the other, in the community. We want people to be successful so that they can go and work in their communities. And that we're facilitating behavioral health workforce development through course development, internships, certification programs, certification readiness. That very often the institutions do not have the capacity, do not understand the requirements, do not have the faculty resources, so we support those activities as well. So now this is my favorite slide. It's hard to read, I know, but I'm going to help you out with this one because it reminds me of an old poem that I had, I think it was second grade. Only thing I remember from second grade was a play, and it's about the spider says, come into my parlor, says the spider to the fly. So now why is that important here? Not because I can remember second grade, but because a spider web is very sticky. So our thinking here is, if we get somebody to latch into this, we got you. So in the center, it talks about the as-is state. We knew there was lack of availability, lack of access, quality, culturally competent services, and that we wanted to change that. We were going to change it with the threads, looking at how we could build awareness, how we could look at cultural and linguistic competency within the context of HBCUs, because we realized the demographic of those institutions is changing. The demographics are shifting there just like the first slide says shifting everywhere else. They're not immune. That we want to look at technical assistance and the coordination of those resources so that we can make sure our support can be used by 105, not just the favored 1 or 2. And that implementation is key. We're very product-oriented, outcome-oriented. The bubbles talk about our priorities. Looking at policy, we encourage everyone that comes through our door to think about policy translation. It's not enough to say, oh, we can't change it, we can't do anything about it. Yes, you can. You can, I can, we can. Evidence-based practices that are based on the populations that are receiving the practice, not somewhere that they wouldn't even know that the group that you decide to work with exists. Looking at awareness and public education, focusing on campuses. Many of them took products that are in the public domain, translated them so they made sense in the student community, as well as the language and the way in which things are formatted, the way in which communication goes. Looking at student involvement, very, very important. Not wanting this to be just for faculty or faculty to write about, but for students to be doing. That engagement critical, workforce development, and leadership. These are the primary areas that we were looking for outcomes around. Our model, because we don't have a lot of money, I don't know who does these days, virtual. We have 105 campuses that are linked virtually. Information dissemination, key. Networking, mentoring, collaboration, without question. Training and technical assistance at all levels of the institution. And that we started what we call a mini grant program. So while we have the largest amount of money going to the primary recipient, we also made provisions so that each of the institutions can apply and receive smaller grant dollars. It gives them an opportunity to practice grant writing. It gives them an opportunity to customize the program for their campus. And most importantly, it allows us to have dollars in place so that students can have paid internships. And we start those internships at an earlier point in their career, so many of the undergraduates are also in this part of the program. So now here, I'm not going through all of this, but it's really to say, operationally, no matter where you are, no matter where you're working, you must think about how do you take the next step from concept to implementation? How do we get from what's on paper so that everyone owns the work? The purple boxes are the pivotal points here. First, we do the network, because we had a lot of fragmentation and a lot of good ideas floating around, but no centralization. That was our priority. Moving from that to looking at the information that's disseminated, making sure that it's credible, that we want it disseminated, because sometimes what people were sharing is not necessarily what you want them to know. How can we facilitate networking? Did I say that? Oh, I'm sorry. So networking at all levels. We want students to students, of course, because we know students are very often the first responders on a campus. But we also want faculty to have a place to go, because in many of the HBCUs, there are no resources for counseling, zero. But we have all these students coming in, remember, with the heightened anxiety, the negative impact of violence, looking at the substance use, that already tells you there's some issues around mental health. So if you are the faculty, you're inheriting the students, you're also inheriting your responsibilities as faculty, so where do you go? So all of that, we look at a multi-level approach, that technical assistance is for everyone. We want everyone to learn so that the community can help the community. And that by having these mini grants, it's changed the portfolio for the institutions. So many of them have now moved on to get larger grants from SAMHSA, focusing on suicide prevention initially, and now looking more to see how we can spread out into HIV, substance use issues, and other capacity expansion opportunities. So now we look at what have we actually seen come out of this. We have a lot of boxes and lines and arrows. What does that really mean? That means for us, when we see awareness and education taking root in a campus. These are excerpts from what students have done. So down at FAMU, they actually went to their TV station. They were the broadcasters. They went out, they found the story, they wrote the story, they broadcast the story. We have an annual communications campaign. Every campus is encouraged to come up with their own social media platform. What are the issues on your campus? What are you dealing with? It is a competition. We posted on our national website, students vote for students. So it's really awesome. And each year we have great submissions. Some are videos, some are print, some are social media campaigns. So they do like the Google chats, or they do Twitter town halls, things of that nature, whatever works for them. And we've also looked at how we can connect HBCUs with other institutions, not necessarily limiting it to HBCUs, believing that we can all learn from each other. So where you see the increased membership in Active Minds, which is a chapter student run to help build awareness and support around suicide prevention. When we started this in 2005, there was one HBCU, one out of 105, that had an organization to offset the challenges of being in an institution and struggling with depression to the degree that you would be considering suicide. That number has grown. It's not as high as we'd like, but what we have changed is the conversation. Initially, there was no dialogue around suicide. We had presidents say that doesn't happen on our campus. And we understood that, because it's hard to say it's happening if you don't have resources to address it. But at the same time, it's hard to believe it's not happening on your group of 105 institutions and it's happening everywhere else. So, we had to juggle that. What about training and technical assistance? So what are we learning? What are we teaching? Suicide prevention was our priority because we want to save lives. But we don't want to stay there. We don't want to always be at the point that we're talking about suicide. So the media campaign training, it wasn't just run a campaign because you have a phone and you know how to make that work. There's some methodology behind that. There's also career potentials behind that. So we actually have a consultant that comes in. He has the only online HBCU magazine for HIV and AIDS prevention and awareness. So he's the person that we call him our go-to person, because he's from an HBCU, so there's that automatic ambassador-like relationship, but he also is a professional and works and is very credible in his field and can give concrete, tangible resources to students and makes himself available as a mentor for them. We have an annual Behavioral Health Policy Academy. This academy is for students. We bring 6 students, faculty, and administrator so that students have chaperones, because we don't want to be responsible for all of that. But the bigger part is the teams develop projects that they're accountable for. They go back to their campus, they implement those projects, and many of them have also gone on to get larger funding. So in that regard, we're looking at workforce development in that pipeline, because for the Policy Academy, we actually have metrics to determine whether or not what you proposed, what we're teaching, does it make a difference? Because it's one thing, everyone likes to go to an event, and it feels good in the moment, but does it mean anything when you go home? Have you learned anything that's changing your behavior? Very similar to that health literacy framework. So if we give out a lot of brochures, if we're not seeing changes in your behavior, then we've wasted a lot of time and money. Our Policy Academy is the only one that's evaluated, so we know that we're on the right track with that. And we're starting to look at the data in the context of health reform. So how can we begin to engage students who are very active on their campuses to engage other students who may not be as knowledgeable about health, health insurance, and the benefits thereof. Student orientation. So the kits are one thing. The pivotal point with this is that many institutions never talk to their students or their families about behavioral health. When I actually came to this school, no one talked to me about it either. So I hope the conversation has changed. But nonetheless, we have institutions where now by policy, orientation must include discussions of behavioral health, not only with students, but also their families, so that they can understand that there are peak periods during a semester when students are going to have heightened anxiety. How to have those conversations. But if you come in with heightened anxiety and then the anxiety is going to get higher, then we really need you to understand what to do and where to go for help. Tips for peer educators. Peer educators are considered paraprofessionals in this environment, so they get paid most often. And when they do, that becomes a part of their portfolio. And they created a brochure so that other institutions could adopt that approach. And the Student Corner is a resource. It's for students to students, so that they have a repository where we're talking about centralization of information. It's also a way in which we can bring people together, not only for one-way sharing of information, but the exchange, valuing everyone's experience and recognizing we have 105 institutions. We should not be silent. These are examples of the products that are available on the website. The website is www.hbcucfe.net. It is not a .gov. So that in and of itself makes it more attractive to communities. We're trying to look at issues of stigma and look at issues of access and utilization. All of the products were developed by students and faculty, and it was just a treat to share with that. So we get to the point of, are we making a difference with the workforce? Because that's part of our goal here. With our internships, we know that we are changing opportunities for students. We're also changing the relationship between the institutions and the community. That's been essential because very often HBCUs are surrounded by communities that are very stressed. And in those relationships where students are going back and forth, they're not always positive. So we wanted to begin to have the institution viewed as a positive resource and the community seeing that as well. The partnerships have resulted in new practicum placements, that we have long-term relationships so that it's not just while you have the seed dollars for your grant, but that the commitment has grown beyond that. And the potential for employment is surprising us. Many of the internship sites, particularly because of the resources that have become available through the Affordable Care Act, are now employing students who otherwise would not have had that opportunity. We recognize that while within our agency and within the network of HBCUs, we're seeing this as a step forward. It's always nice when others see it. So here I just pulled a couple of examples. One was the mayor in Baltimore recognizing the students for some of their early work, and also for their governor giving them a citation, which, you know, there is a time where all of us like to have a certificate to take home or share with somebody, but for these students, it was a way of affirming hard work, because they're also framing conversations in a context that's very difficult to have those conversations. So we've given them skill sets, and they've helped us learn skill sets that have allowed us now to move from not having anyone to talk to us to having dialogues across institutions. And we're really excited that we are able to lift the model now from not just HBCUs, but we're moving it forward to tribal colleges and universities. So in the sharing of the evolution of the work, we've gone through 3 funding cycles with the HBCUs. The tribal colleges, known as TCUs, have also been funded through NIH. So their approach will give us even more information, because not only will they have a similar model, but they also have research dollars, so they can test where the model is strong and also show us where it could be improved, or in some cases where we could just take that piece out. Well, we know that's an improvement, but sometimes that's like almost amputation. But that's a good thing, because we need not to do what's not effective. This is the blueprint for success. We developed it after the first 3 years. At that point, we recognized that there has to be some way to document the story. We're now in the process of looking at new mandates. Our mandates are, simply put, that with, I know this morning we talked about a number of policies, Healthy People, we've talked about Affordable Care Act. One thing I didn't hear, maybe I missed it, was the HHS Disparities Action Plan. So it is a very specific plan that was released in April 2011. And if you haven't seen it, I encourage all of you to do so, because it is the most exciting product I've seen come out of HHS, where it has a very deliberate plan for how all agencies within the department are to address health disparities. And it identifies the agency. And it also says what the agency is supposed to be doing. So it gives the public an opportunity to know, where is your money and what is it doing? But one of the top, well, the top priority, actually, it's not one of, it is the top priority for the secretary, is that we look at disparity impact statements across all grant programs. This is one of them. So what we're looking at now with our data is, not only are we moving forward to success as we framed it, but are we making a difference in the health disparities that students experienced? And are we making a difference in the workforce diversity from a very specific way? So we're excited about our impact and where we're going. This map shows you where we are. We started with one willing grant recipient, because when you get the check, you're always willing. But now we're in all 105 HBCUs, not at the same level. So I won't put that out yet, but we're close. But we have everyone engaged. And where there are multiple colors, doesn't matter that you know which city it's in. What's important is that they are repeat customers. So when I talk about those mini grants, they're contagious. They're exciting, because these are people who are getting money for the institutions who are not a part of that pipeline that are always getting the grants. These are people who have never written grants before. These are people who would never have the opportunity to be funded. They are required to work with students. So not like at Teachers College, these in many cases are undergraduates or community colleges. So the pipeline is very different in this environment. And that's what's exciting us, because we are able to keep people engaged in a professional pipeline before they are so stressed and so burdened with debt that the next viable option is Walmart. We're trying to stop that. We want people to be able to fulfill their dreams. So we have, for sure, greater impact across behavioral health awareness. That one we go ka-ching. We know that there's increased access and use of behavioral health services on all of the campuses. Not all of the campuses to this day have resources that are campus specific, but they at least have community partners, so they have referral sources and capacity to get help for their students. We know that we have expanded capacity for screening, for prevention, screening, and early intervention services. Initially, they used the College Response Program. Now they're using something called Cognito, which I know is here in New York City. Many community health clinics use it. But it's an online tool. Students can do their assessment, but it's a way of building awareness. And many campuses have indeed linked their online assessment with a referral pipeline, so they're catching students before they really get into trouble. And the internships, we're thinking now how we move the internships that are in this context into our minority fellowship program. So I'm also hoping that all of you know about that program, because that's not my focus today, but it's really an important resource for all of you who have tuition to pay. But the point here is if we have students in a pipeline at a community college, then going to their undergraduate work, if they are successful in the master's work, we still want to have resources for their doctoral work, and the Minority Fellowship Program is an important environment for that, particularly when we have that lens around behavioral health, because those are the associations that are pivotal for accreditation and licensing. So we're moving forward. We're still looking at a few elements around feasibility for using the model with other groups of institutions. We are excited about the work with tribal colleges, and hopefully this year we'll have conversations with those institutions that are thought to be Hispanic serving institutions and those that focus on the Asian American, Native Hawaiian, Pacific Islander institutions. We think that we're still learning, but we've learned enough to begin the process of moving it out so all students could have this opportunity. And in some cases, particularly there's SUNY in Albany, we have looked at some of the work that they've been doing with their student population. It mirrors very much what's happening in these minority serving institutions. So we're also exploring how we can broaden the conversation so that it's not just about minority serving institutions, but eventually all students and all those who need some resources and support around behavioral health. And that data, of course, is important. So we have like piles and piles of data. We're always looking for volunteers to come help us read and write, but we also bring interns into the office, and some of our efforts now are really looking to see what are the numbers telling us and how do we begin to make changes so that we can increase our impact and effectiveness. So I'm coming to a close here, and it is one of hope, even though it's a little dated, because I wanted to share this as it focuses on a point that was almost striking, because it makes me, and I'll share that in a minute, but the fact that the nation's health professions have not kept pace with changing demographics may be an even greater cause of disparities in health access and outcomes than the persistent lack of health insurance for tens of millions of Americans. So this was 2004. So the point of hope is now we have the possibility for those people to have health insurance. So if that's possible, then it is definitely possible for us to address the disparities in our health professions. And I thank all of you for sharing that commitment with me and with those who are not in the room, but definitely of the same mindset. And with that, I thank you for your attention. I think I might have time for one question if it's an easy question. All right, thank you.
Set of information that you've presented this evening. I'm very interested in the tribal colleges and what the dynamics between the tribal and the HBCUs. Mm-hmm. And on top of all of that, there are those colleges called the land-grant colleges, which, you know, UCLA and University of Pennsylvania, big universities where lots of money and grants go that probably would be 10 to 1 to a HBCU and a tribal college. Can you describe, explain, or just talk about in any way the differences between the pipeline and the funding resources for HBCUs, tribal colleges, and the land grants?
So I thought it was an easy question. The easy question is the answer, right? So, but I think you bring a very interesting point. When we initially thought about sharing HBCUs and tribal colleges, so HBCUs and TCUs, how do we bring the group together? Because we were having parallel conversations. So the HBCUs were very clear that they were willing to share what they'd learned, and there was no problem. And the TCUs were very willing to talk about the TCUs and what they need, and no problem. But then it's always when you come together and say, well, we have money in place for the HBCUs, but we don't have any additional dollars for the TCUs. I didn't say that. That's why they went to NIH. So when we had the first official conversation, we brought the team from the grantee is Morehouse School of Medicine, so I definitely want to give them credit for all of what I shared because it's their work. But we brought them to Washington, and the tribal colleges are organized a little bit differently. So it's much easier to bring them together for a discussion because they function collectively in a very different way. So everyone's around the table. So this is where you get to, collaboration is not the goal, but it's definitely an important first step. The conversation was so rich, and the immediate response was, what's happened for the HBCUs has relevance for the tribal colleges, but it can't be the same. You know, we can't just pick it up and take the model and drop it down for tribal colleges because we need to think about language issues. Many other tribal colleges are multilingual because many across generations, you know, they're using their native languages, and many of the courses preserve that. So the cultural framework is embedded into the health perspective a little bit differently than in some of the HBCUs. But all in all, the general framework was acceptable. Then we had to have a separate conversation with just the tribal colleges so that they could begin to own the work and refine it so that it met cultural and traditional perspectives across all 33 tribal colleges. So before they came on board, all the tribal colleges were on board. All their presidents and their student congress agreed. And they have, they actually made a resolution to prioritize behavioral health on their campuses. So the launching was a little bit different, and it gives us a different perspective in the cohesion, and it made, maybe because they're smaller too, so there's a third of the tribal colleges, that also makes a difference. But the way in which the conversations grew from the onset just took a slightly different path. But to this day, people are still collegial and collaborative in how they're learning from each other with the work. So when we talk about peer educators, it's a little bit different for the tribal colleges. They have a different name, they have a different focus, a different priority. But I think for the most part, the fact that there was money for one and not the other didn't matter. It didn't matter. They were so determined that it wasn't like a highlight of the conversation. I don't mean to misrepresent, but it didn't deter them from going forward. And now they are fully funded and can do things with their campuses in a good way. Now, in comparison to other institutions that are funded differently, our concern is not just the dollar difference, because it's significant and it does matter, but it doesn't always matter in terms of student engagement. Because if students are not feeling connected to the process, or feeling that they're safe, or feeling that what you're offering is credible, they're not coming, regardless of how your school might be resourced. But what we're concerned about is that in these larger institutions that have a large, diverse population, and we are not yet having the conversations about how to tailor the services so that they are culturally and linguistically appropriate, that those students are now at a disadvantage. So we have other grant programs that are starting to look at that, so that more campuses can have opportunities to focus on student behavioral health. Mm-hmm.
We can handle one more question.
Okay. Hi. Thank you for your presentation. I attended the University of Maryland Eastern Shore, in Princess Anne, Maryland, one of the HBCUs. And I remember as a student there were two incidents. One, a student committed suicide on campus, and he was European. A European student. And another incident, we were all told to go to the auditorium because one of our classmates was found. She was shot in her back by the tracks, and we were informed that it was her boyfriend, or that was the information going around. Now, the reason that I bring this up is because you spoke about the model. You shared with us the model operational framework regarding student and staff resources at the HBCUs, which I'm glad to hear about that because that wasn't available at that time. Those sorts of resources weren't available for students or even for the faculty to deal with that. If the faculty received questions from the students, those resources just were not there. So I'm happy that you spoke about that, and it's really important, and not just surrounding suicide or deaths, but students attending college, leaving home, and having to deal with that transition. What do I do? Yes, I'm looking forward to being on my own, but what does that truly mean when I'm now in a setting living with total strangers and I don't have that family support system that I had at home? So it's really, really important for success, for students to be successful. It's very important to have these types of resources in place. So thank you.
Thank you for that, but I also want to just respond by saying I'm really sorry that happened to your campus and it happened to you. So I'm sorry about that, because whatever happens in the environment happened to you, and that's tough. And I also want to be very honest and candid. These resources are available. We also have to continuously encourage people at decision points in institutions to receive them. So very often we give, anyone can give, but if it is not received, it is as if you didn't give it. So I don't know when the incident occurred, but I'm talking about a long time ago. So from 2005 to now, that's a long span. And when I say we're everywhere but not at the same level, then that means I recognize that I could go to any one of those campuses and not see anything that I just shared with you. I can go to other campuses and see that and more. So the unevenness may also be what you experienced. But the important thing is that you can use your voice, you are using your voice to build awareness, to strengthen that community, and to help people understand how important that conversation is. And if you still need resources for people that are there or that I'll be more than willing to make them available for you, because that's not something you want people to not have.
This happened a while ago, but because you mentioned this in your presentation, I remembered the incident.
And that's why I repeat, because it happened to you.
Right.
You're welcome.
Thank you. Okay, so the second comment for the first presenter, Dr. Wallace, when you spoke about the formation of the research group, yes, I actually participated and I benefited from that and the collaboration and being under a lot of stress and still having to deal with life outside of the room, outside of the group. And it was something that we looked forward to because that's something that we knew that we were able to all communicate about the same thing. We were all having different struggles, and we had each other to support one another, to make sure that we did what we had to do. And yes, Dr. Wallace was on our backs, to make sure that we did what we had to do so that we were able to produce a document that was worthy to be read, as well as to be prepared for our defense. So it is important, and when I went to Kenya, I saw the importance of the group collaboration even just around food, preparation, the food preparation, what happened. They didn't just cook food at that time, but they discussed what was the different things that took place in their families. So the women were cooking or preparing food, and it was a group event, a communal event, and that's what I had the opportunity to experience in our Wednesday sessions. So thank you to come.
Thank you. Okay, so much gratitude to all of you for coming to the session. And I think that, why don't we clap? That was such an outstanding presentation. And such a wonderful presentation style. So I'm just so delighted that you're able to attend. All right, so remember there is a reception from 5:30 to 7:30, so you can head toward Everett Lounge. Thank you so much.